It sounds kind of strange that as a fully grown adult, you could have been pooping wrong this whole time.
I can't believe there are people in this world who don't look every time they go to the bathroom. Like, so you should
Crossing the street and pooping.
Yeah.
Always look.
100%. Thank you. Yeah.
Dr. Pasricha's new book, You've Been Pooping All Wrong, provides an honest, accurate, and unintimidating look into the science of your stool. What is the number of poops per day that we should strive for?
Everybody right now listening is going to think that answer is 1. How many times a day would you think is normal to fart? A lot of people can't poop on vacation.
What does the color of your stool or your poop tell you about yourself? We talked about what warning signs to look out for, when you need to go see a doctor, and the genuine risk that comes with bringing your phone to the porcelain throne. Huge thanks to Microsoft Dragon Copilot for sponsoring this video. The topic that I'm excited to talk to you about today is one where I feel nuance has been probably missing from the most. Is that a fair statement?
I think so. I mean, if we're talking about health information, especially health information online, nuance is hard. Nuance is hard. And, in my field, I'm a medical journalist. It's a little bit of a different category than the traditional sort of medical influencers. It's a different category than a lot of doctors. And all of these different groups have an important role to play in the ecosystem. But all of them, I think, take that idea of nuance a little bit differently, and they interpret it differently, and they kind of have to because the mediums can be a little different. Yeah, that's very true. How did you find yourself where you are today? You're a neurogastroenterologist? That's right.
Yeah, tell us what that means.
Yeah, neurogastroenterologist. It's a fancy word that means somebody who studies the gut-brain connection. So it's someone who goes through internal medicine training, GI fellowship, and then a special fellowship for neuro-GI. It's kind of a new field, like in the scheme of things. It's been
During
around.
that fellowship, are you doing mostly research? Are you seeing patients that have a gut-brain potential diagnosis?
Yeah, it's both. So, and I think every fellowship program is a little bit different. It's like probably a mix of research and patient care. We study probably the most common disorders in GI, like irritable bowel syndrome is one of the most common disorders in GI. And so even though you might think neuro-GI is a little niche, it's actually like one of the broadest categories of patients that we see. So irritable bowel syndrome, but it's a lot more than that. It's like chronic unexplained abdominal pain. Right? That's something that we see all the time. We often don't put a label on it. One word could be functional dyspepsia. That's all us. That's what we see. So we study pain signaling from the gut to the brain and vice versa. And then in my world, my NIH grant is studying Parkinson's disease of all things. And a lot of people are like, why is a gastroenterologist studying Parkinson's disease? And it's because I study how Parkinson's disease and other neurodegenerative disorders might start in the gut. So it's a lot of different things. It's a cool subspecialty, but it's kind of a relatively new one within GI.
Right. And how did you transfer out of that to doing medical journalism?
That's a great question. I had always been interested in journalism. I actually thought I was going to be a medical journalist way before I knew I was going to be a neurogastroenterologist.
Who wakes up with that as a dream? I'm curious, what led you to that path?
Any Indian American who grew up watching Sanjay Gupta.
Okay.
I think
And you're following in his footsteps. He was here 2 weeks ago, 3 weeks ago.
He is. Yeah, he's been one of my mentors like for the last couple of decades. He's a wonderful person. And he, at that time, like, so I grew up in the 1990s and 2000s. What he did, and what a lot of, there weren't that many medical journalists, as you know, he's certainly one of the more prominent ones. What they did, I thought, was so cool and unique. Like, they took what I thought was the best of medicine and the best of storytelling, and they put it in with this journalistic rigor and ethos, and they put that information out in the world. And that's what I wanted to be. And so when I was in college, I interned at CNN with him, which was the best experience. It was lovely. And it really, it did make me say, yes, I want to be a journalist. But actually the incredible thing was that, I've told him this before too, it actually really made me say, I need to be a doctor too, right? Because one thing that is true about him, and I think true of probably any good science communicator, doctor, influencer, medical journalist, is that they put patients first. Right. And I think that's like the number one thing that I think a lot of other journalists don't have to grapple with.
Sure.
Right. But he, the lesson that he taught me that summer, it was one summer, was that whatever the story was unfolding on the ground, like he'd be on camera, he'd be in these different countries, there was a great story to be had. Often it was like in the middle of a disaster. There was like a big earthquake he was covering. And if there was a patient in need, he would say, you need to stop the camera because I'm going to assess this patient. And when I saw that play out, I was like, wow, this is this is the real deal right here. And this guy is the real deal, you know? And like, that's really what I want to be. So, so I said, okay, let me go and come to medicine. So as you know, I spent the next like 15 plus years in training as one must. And only in the last like maybe 4 or 5 years, I was able to get back into journalism. The pandemic was a big sort of instigator for me to come back into that world.
Well, let's talk about gut health because we've been pooping all wrong this whole time. What does that mean? Because I thought I was doing great. I got stickers when I was in kindergarten.
Like when you were 2 years old? Oh, kindergarten.
Yeah.
Whenever it was.
I mean, maybe I was in Russia at the time, so I don't remember. I probably got the belt more than I got the stickers because it was USSR times.
Good Lord.
So, but tell me why we've been pooping wrong.
Well, you're right that I think most people don't remember most about what they learned about pooping, except for what they were being potty trained, which was at an age when we probably don't remember much of that conversation. Our parents remember it. I am deep in this conversation with my 2-year-old son right now. I guarantee you he's not going to remember what we talked about later. But that's kind of the extent of the conversation that you get about how you're supposed to poop. What are the mechanics of pooping? And
what is that best-selling book, Everybody Poops, right?
Yeah, we read that every night.
You do?
Yeah,
every night?
We do, right? Wow, because I'm telling you, we're in the trenches right now.
Okay, got it.
We have like 5 different books about pooping that we read.
Okay.
But it's whatever you got told by your parents when you're like 2 or 3 years old, maybe 4, 5, 6. That's probably a very similar conversation to the conversation that they got from their parents when they were younger. And that like it gets passed down from generation to generation, I think, without people ever really learning about their bodies in the way that I think they should. So for example, brushing your teeth. We learn how to brush our teeth initially from our parents, but then we get this check-in with our dentist at least every 6 months, maybe every year, like depending, but usually every 6 months for the rest of our lives, where a dentist checks in is like, here's your technique. Are you doing it right? By the way, you've been flossing wrong. Oh, are you getting your gums? Are you like doing all 4 quarters? Like all of this stuff. We don't get any of that for pooping, you know? And I think when I became a gastroenterologist, I grew up with a gastroenterologist as a father. So we talked about pooping like all the time.
Really?
Like we had a really fun household.
What was the poop conversation?
It was like every morning, you know, like some dads would be like, hey, like, how was school today? Like, did you do your homework?
Your dad would ask you, how's your poop today?
Yeah, he'd be like, did you poop? First of all,
Wow,
did you?
okay.
Yeah, like, and then.
So was there shame if you didn't?
No shame. There was never shame. I mean, that's the key. There was no shame, but there was, I don't know, maybe judgment. There was just like a, hey, like.
Concern.
Yeah, concern. Yeah, there was like a healthy amount of like, why not? Like, what do, you know, like, what do we need to, and he was like very excited. This is like his favorite topic in the world. It quickly became my favorite topic in the world. But I think I grew up knowing a lot more about pooping and the mechanics of it. And he was also a researcher. And so I think that was like partly what got him really excited and telling me about all the stuff he was doing in his lab. But when I started seeing patients on my own, first of all, a statistic that blew my mind as a gastroenterologist, so I do this for a living, is that 1/3 of people will avoid seeing their doctor about their bowel symptoms because they're so embarrassed. That's a huge number.
Wow.
Yeah. And another statistic that I started to learn, but then it like made sense with what I was seeing, is that in America, 40% of Americans say that their bowel habits disrupt their daily lives. And so clearly, I mean, that's a big number for people who, like, we don't have it together the way we kind of assume we do, considering we don't really talk about this with our friends as much as we should. We don't talk about it within our families. In fact, we kind of like treat poop jokes as like really immature, and like what happens behind the closed door is like your business and nobody else's. And as a gastroenterologist, like this is our, you know, like what we do every day. Like we're asking everyone about poop. And I sort of found that people were, one, really embarrassed. Even people who'd come to my clinic who like have a need, made the appointment, waited weeks to see me, like they would sit and they'd squirm in their chair, like unable to find the right words to kind of get it out. And it's hard to see because, again, like this is what I do for a living. There's like nothing that you could say that would embarrass me. But I wrote this book because I realized there's just this huge gap between when we were potty trained and when we become these fully grown adults who are like sitting in my clinic, sort of like not sure what a normal poop looks like. And even people, maybe you're in this category, maybe you're not, but people who think they have it under control, think there's no problem there, there's actually a lot you could learn. I think about how to maybe optimize a little better, how to improve all of your gut health as it relates to pooping. But you just don't know because we're not really having that conversation out loud.
Are people doing something wrong when it comes to their bowel habits in general?
Yes.
Like, is there a pattern that you're seeing?
Yes.
I mean, definitely the TikTokification in the bathroom leading to hemorrhoids, perhaps. But anything
That was my study. Did you know that?
No. Okay. No, tell me about this study. Because that's just something I see with all my patients that I'm like, well, how long are you spending? Well, you watch one TikTok and then you're down the rabbit hole.
Right. You don't watch one TikTok.
Yeah.
Okay.
I don't know
watch one.
Who watches one TikTok.
Yeah. You go in there and like full details of the latest celebrity divorce. Like 45 minutes later, you come out of there, you're like ready to have that conversation. Well, so this is actually a fun example. So like when I write my column, usually what I write my column about is what readers send in questions. Like we have this forum, they can send me questions, people could DM me. And they're usually like fantastic questions.
Do you get weird ones?
Yeah, of course I get weird ones.
What's the weirdest one you've ever gotten?
Okay, can I tell you the weird one?
Yeah.
Well, I will say like the most common question I get is like people asking me really specific medical questions which I can't answer. And that's like really tough and like sad to, like not be able to respond to. But I got this great one that was like, okay, do you consider the gut inside or outside of your body?
Yeah, that's
yes, because you can think about the gut
worm.
as like a donut. Yeah. Or like, right. So is the donut hole inside the donut?
Yeah, I always say everything's outside.
Get out. I think the gut's inside. I'll tell you my argument why.
Oh, okay.
I think it's inside.
Okay.
Okay, my argument for that.
Okay. Yeah, because I don't really have an argument as to why, but I'm just like, if you swallow something and it comes out, it never was in.
Okay. I see that argument.
Non-digestible object.
Yeah. Like, so the fiber component.
Or the non-edible things that some people accidentally swallow.
That's true, that we go fish out at 12 a.m. Yeah.
Exactly.
Well, I think about it, and I think this is a deeply philosophical, like we could argue this, but, at the beginning and end of the GI tract, you have two sphincters that usually stay pretty tightly closed. The lower esophageal sphincter, you can consider that one anyway, maybe the mouth, but I think I would start with the lower esophageal sphincter. And then you've got the internal and external anal sphincters. I think when you have those sphincters that are closed, and then along the way, you've got like the ileocecal valve, which is pretty much a one-way valve. Like I think there's not really that much flow. Once it's in, it's not going back up. Once it's getting towards the end, like it's gotta go out. You know what I mean? And so like, I think once you have like these closed doors, what's inside is an inside space. Like you can let air out.
So you're saying it's like revolving doors.
Yes.
Don't make a space outdoors.
Yeah.
Wow, that was a good line.
That was really good. Yeah, it's like, it's not an atrium, right? It's not like this open passage of like free flowing. It is like a revolving door type situation.
If we're arguing about airflow, and there's obviously airflow throughout the GI tract, but there's also airflow when you have a revolving door. It doesn't mean that
the
lobby is outdoors.
The lobby's inside.
Yeah.
I think we could all agree. So anyway.
You may have changed my mind.
I hope so. I haven't published this question yet because it's been like bothering me so much. It keeps me up at night. How did we get here?
That was the weirdest question you got asked. People ask you questions about poop.
In the last week.
No, come on, weird. Give me something weird.
Well, okay, I get a really common questions, which I don't think are weird. You can tell me if you think they're weird, but these are the questions that I get. Like people will be like, "Hey, I had this like bright orange poop. What do you think about that?"
Okay.
And these are like the kinds of questions I get in clinic all the time.
Okay.
Or they'll be like, "Hey, my poop was like purple this morning." And first of all, I usually tell people, like, pics or it didn't happen. You have to show me what this looks like so I can like evaluate it in real life. Like I can't just take your word for it.
See, when you said the percentages of people being embarrassed about their bodies, about their bowel symptoms, I have a lot of patients that are like, "Can I show you? Can I show you?" And I'm like, right now I don't need to see. So
this is where we
do
differ.
You have motivated patients that want to show you?
Yeah. Well, there's like another extreme too, right? It's like a little bit, but I actually am like very encouraging of this behavior because I love a picture.
Okay.
It's so much harder to describe your poop, and then people want to dance around it and be delicate. In fact, that's like why I use the word poop in the first place. Like you'd be surprised. Well, you might not be surprised. This word offends a lot of my Washington Post readers.
Really?
Like I get a lot of, speaking of like funny questions.
Wait, they want excrement? Like what's the...
Well, yeah, they're like, first of all,
feces.
They're like, this is like, why is a doctor using that word? Like you should say bowel movement or BMs, or like maybe you shouldn't talk about this topic at all. And I'm like, well, you see the problem we're running into here.
Exactly.
So like when I started writing about poop, it actually came from, so when I was a student, I had this one like wonderful GI mentor who I had shouted a lot of gastroenterologists because I thought that's what I wanted to do. And he was the first guy who a patient came into his room and he was like, "So tell me about your poop." And when he said that, and I was like, this is so weird, like a doctor's using that word. But that patient was like, so you could just
at
see
ease,
it,
like, oh,
the relief.
yeah.
And so then when I became a doctor, I was like, you know what? I'm meeting people like of all ages, like all backgrounds. And I tried to say bowel movement. And I later had some of my like college students who would come to see me as patients being like, I didn't even know what a bowel movement was. Like that was the first time I heard that word. And you made it weirder. Like you made it feel like I couldn't really tell you what was really going on. When I say poop in my clinic, and like I let people lead, like I don't really care. I don't care what word we use, but like when I say a word like that, like everyone's relieved. Like you just like this wall breaks down and then they know they can say whatever word they want to use afterwards, you know? So it's like, it's the word I use that's like safe, but I get a lot of comments and questions and letters to the editor that's like, can she never write that word again?
You need, did you finish editing the book in terms of chapters and everything?
I did. Yeah.
Okay. Because I was going to say, you should have a chapter called Why Censorship is Poop. Because that's very apt for our conversation.
Yeah, exactly. I do have a whole, like a little bit of a chapter about like why we don't talk about it, like what the response has been. But then it's like, I do think that that's like the 1%. You know, like I think 99% of people are like, thank God, right. Yeah, like we can just talk about this like comfortably, freely with a judgment-free space. And that's the goal. Like if you have somebody, listen, it's happened a couple of times that I've been like, well, tell me about your poop. And I can see that I've made it worse. Like that person's like, I beg your pardon. And then I'm like, you know what?
BM.
Yeah. Then I back. Like I want it to be whatever word you want it to be.
Right.
But usually.
It's like when people come in, it's how would you like to be addressed? How would you like the excrement to be addressed?
The excrement in the room.
Two questions.
Yeah, exactly. Yeah, exactly. That should be in my intake form.
Okay, so we know that people are spending too much time.
The smartphone thing.
The smartphone thing.
So,
yeah. Tell me about the smartphone thing.
I lost track, but so usually I get questions that inform what I'm going to write about. In this case, I had gotten this question about hemorrhoids, and we wanted to write about hemorrhoids for the column. And so, look, I'm a gastroenterologist. I know, just like you know, we tell patients all the time, don't spend more than 5 minutes on the toilet, right? And so for my column, what I like about the column is it gave me a chance to do some nuance, some deep digging into the research. I was like, I'm going to tell people where that 5 minutes come from. I'm going to tell them why we say that.
Yeah.
And I did all this digging, and there's actually like, there wasn't a good data. The best data, and this was like, I love this. There was a 1989 study from the Lancet. Like, this is what it took. Me too.
Oh, 89 babies.
Great year. Yeah, I know. What a time to be alive. At that time, and like as a scientist, like if someone publishes in the Lancet, I'm like, wow. Like that's like, you've achieved something great. And this is what it took to get published in the Lancet in 1989. They did a study of about 100 people. It was a cross-sectional study.
Okay. People
came in. The like colorectal surgeons in England in this one clinic asked them, do you read the newspaper when you poop? Yes or no? And maybe how much time they spent reading the newspaper. And then they peeked. They looked and saw if they had some hemorrhoids or not. 100 patients, cross-sectional study, made it to the Lancet, and they found that reading the newspaper was associated. It's not a logistic regression model. It was like just a kind of a
simple
correlation.
Yes or no,
I know. Like was associated with hemorrhoids. And
how strongly?
Strongly.
Okay.
But that was the best study I could find in like decades of like why this is the case. And of course, we know, like this was in my childhood, like people were reading old magazines in the bathroom. You had those like old-fashioned bathroom bookshelves. Nobody's doing that anymore. Everyone's bringing their smartphones in. So there was no data. So this was like a cool example of where I was like, I'm taking this reader question and I'm going to do the study. Like I'm going to answer this question in my own lab. So we asked people coming in for their screening colonoscopies at Beth Israel, do you take your smartphone in? Yes or no? How long do you spend on the toilet? Like do you exercise? How much fiber are you eating? All these things. And then we looked during the colonoscopy if they had hemorrhoids or not. And it was true that we too found that taking your smartphone into the bathroom was associated with this 46% increased risk of us finding hemorrhoids. So that part we kind of like had a good feeling was going to be the case. But what we also found is that most people who brought their smartphone in also said that they spend more time in the bathroom by accident. Like that they don't intend to spend that much time in the bathroom, but the smartphone sort of makes them. And they were 5 times as likely to be spending more than 5 minutes at a time. So it's not like it's not a randomized control trial of will you get hemorrhoids by using your smartphone? Sure. I would love to have 20 years to do that trial. But it's as good as we get, I think, in the smartphone era.
If Kevin Hall was not removed from his post studying metabolic medicine in the NIH, he has those metabolic labs where for 2 weeks, sometimes 4 weeks, he would have people that he would really control their diets.
Yeah.
It would be cool to have seen those people have some sort of marker that when they went to the bathroom, it flagged the time that they spent in the bathroom with their cell phone.
Yes.
And then, because it's already a research institute, get that answer of, oh, on average, people spent this long. And once they hit this marker, the chance of them having hemorrhoids was this much higher. That would be cool.
Yeah. I think that is a good study. I also want to do a study. We have this test called an anorectal manometry. Have you heard of this test?
No.
It's a lovely study. So it's just basically 1 out of 3 people with constipation who've been trying laxatives, the issue is not really that their colon's not moving and squeezing or even how soft the stool is. The issue is the pelvic floor. And so that's 1 out of 3 people. And so we do this test in neuro-GI called anorectal manometry where we basically, this is going to sound weirder than it is, but we put a small balloon in your bum and you push it out. And that balloon has sensors all over it. And then it measures like what the pelvic floor muscles are doing. Are they contracting at the right time? Is there productive action? What I believe is the case, we're trying to do this study, is that I think when you're sitting with your smartphone and you're like kind of like enmeshed in like whatever doom scroll you're in, I think your pelvic floor muscles are not coordinating as well as they should. And I think that they're, the whole idea about why sitting on an open bowl for like too long, this 5-minute rule sort of came about, is because we think what happens is that, on a toilet, there's no pelvic floor support. Like on a chair, like we're sitting against something that's giving us some counter pressure. You're not getting that with an open bowl. And I think that passive pressure, all hemorrhoids are veins, right? They're just veins that become engorged when there's more pressure. And so I think the longer you spend over time, you spend more than 5 minutes every time, but you do that every day for weeks to years, I think that's what leads to the development of hemorrhoids. But I think also that pressure causes those muscles to start to contract that shouldn't be contracting, and the ones that should be sort of maybe increasing with their pressure to like augment it, you're distracted, so they're not doing that. And I think it leads to long-term pelvic floor dysfunction.
Got it.
This is what we're working on. If you want to know like the exciting frontier in my lab, that's what we're working on.
Got it. Hot air balloons up the bum.
Yeah, thank you. Exactly.
Yeah. Because I'm family medicine, I would need a good screening question. So for example, before I give someone a PHQ-9 screening questionnaire, I do the PH2, which I ask them 2 screening questions that if they flag, then we go deeper. So maybe in this case, we ask them a screening question like, have your legs ever fallen asleep while you were on the toilet? If they say yes, we're screening for hemorrhoids.
Yeah, we're just going to take a quick look in there.
Right? Wouldn't that be a great question?
Yeah, rather than, because I think it's a useless question to be like, do you bring your smartphone in?
Yeah,
because
everyone's going to say yes.
Yeah, or they'll say no.
But if your legs are falling asleep, that's a sign.
That's deeply concerning.
Yeah. And again, that's not medically validated, but it just feels like it would be medically validated.
Oh, I think, yeah. Well, actually, this is like a fun fact about pooping and hemorrhoids. Varicose veins, the same risk factors that lead to hemorrhoids, constipation, straining, low fiber diet are what leads to varicose veins because they're all connected. And so, I think there's totally a valid reason. I had a lot of, when this study came out, like it got a lot of attention, right? Because it's like who cannot relate, right? Even if you think you don't relate, you relate.
Yeah.
I got a lot of like pushback from like, so I have 2 toddlers. I got a lot of parents who are like, okay, but like going to the bathroom and having my phone, that's like my only me time, you know? And I was like, I get that. Like I can't even go to the bathroom without like my dog coming in. Like it's like a blessing. But I think that people, like you don't have to reach the point that your legs are falling asleep. Like you should still feel like you have your me time. Doom scroll away. Yeah. But I just think like
don't do it in the bathroom.
Put the seat lid down and keep your pants on. Like we don't have to do this in this like compromised position.
Yeah. Good point. Okay, so that's a big factor in our lives.
Totally.
Treatments that we're overusing or underusing for hemorrhoids.
Well, I do. The most underutilized treatment is, of course, fiber. Like all of us, like 95% of Americans, we're not reaching our fiber goals. Fiber is one of those things that it's like the most boring answer you can give anyone for what they need to do to improve their gut health. And yet it's like the hardest one to achieve, right? Like I think the most overutilized, and it's not for hemorrhoids, but like any kind of supplement is easier than getting more fiber in your diet, except maybe a fiber supplement, which I'm okay with.
But even in that regard, isn't it not as clear that it's just the fiber that's getting the patient all the benefits?
Totally.
Or is it the combination of the fiber plus the phytonutrients and all these other
It's
variables?
always better to get it in your diet, right? Because I think we can do really sophisticated epidemiological studies, and they have, to the best that we can, And yet, I think we're never going to be able to fully, in epidemiological studies, say this was purely the contribution of the fiber versus exactly like all of the other nutrients. However, in terms of fiber supplements, psyllium husk has been like sort of independently studied as like a supplement for hemorrhoids. It's been studied for fecal incontinence, which affects about 7% of Americans. So I do think if you're going to do nothing else, changing your diet's really, really hard. So I think if you're going to do nothing else, like psyllium husk is probably the oldest and best studied supplement, but it's never going to be as good as changing your diet in a way that incorporates whole grains with all of the other nutrients that come with that, like colorful fruits and vegetables. All of those things are hard to distill into a capsule.
What do you say to people, because I know some folks in my personal life that I've given that recommendation to, that say their body doesn't tolerate fiber well?
Yes, that is the most common sort of pushback. They'll be like, but I try, and then I immediately bloat, and it's so uncomfortable. Well, one, I think we should investigate whether or not that person has something like irritable bowel syndrome, or there's some other pathology going on. So, but in somebody who maybe there's not a disorder or a disease process that we should think about, it's common that I usually, when I tell people we need to increase our fiber, which is applicable to almost everybody, I never say we need to go from 0 to 100 overnight because it will cause a lot of bloating and changes. The nice thing about the microbiome is that, as you know, when we're born, those first few years of life are at the time when our microbiome is most malleable. Afterwards, we kind of get set in our ways for the next several decades of our lives. And really the biggest way we can change our microbiome afterwards is diet. And most of the studies have shown that it takes 2 to 3 months for our diet to change our microbiome. And meaning that if we start to increase our fiber intake, it very well could be uncomfortable for the first couple of days, even weeks. But if we increase it slowly over time and give our bodies a chance to respond to it, to change, for that microbiome, maybe those species to shift a little bit, I usually find people are able to tolerate it if they go low and slow, but they eventually, they get there. So I think when people say but I've tried it and it was awful, I usually say, let's start over and let's just start low and get there, because it's better. I mean, ultimately, eating a high fiber diet in the long term is so much more important than like the short term win by avoiding the high fiber in the first place.
Yeah, it's interesting because I've also seen patients who I've recommended fiber supplement to that actually they were, let's say, not perfect, but we wanted to optimize them a little bit better. And they said, oh, this actually created constipation in them and had sort of a paradoxical impact on their GI health. And I'm like, whoa, did not expect for this to happen.
We didn't want it.
So I guess you're saying it's because of the microbiome changes
Well, partly. It depends on the fiber too. Like what I like about psyllium husk, which is a salt, like there's people will beat to death like the difference between soluble and insoluble fiber. And if I'm being honest, I usually don't tell patients to worry so much about it, because in your diet, it's a mix of insoluble and soluble, and I'd rather
with a
just
supplement. You can have the people taking these gummies that are not the correct form of fiber, or sodas that have fiber that's not really fiber. They're basically hijacking the term fiber, because of poor definition set forth by the FDA.
I think if fiber shows up in an ultra processed form, we need to take a step back and say what were we trying to fix in the first place? But I think so. Soluble fiber, which is the kind of fiber that you put it in a cup of, you're supposed to take it with water if you take it in the capsule form, and it's present in a lot of foods. It's the kind that turns to gel. And I actually I sometimes take psyllium fiber myself because I don't always meet my fiber goals, but I like to overdo it. If I don't drink, I put it in my coffee, if I don't drink that coffee quick enough, it will turn into jelly, and that is not fun. So this turns off a lot of people, but that gel is what gives it the ability to add bulk to the stool. And so it can, for some people, it may cause a little bit of constipation, but it can also kind of loosen it up. It sort of is supposed to be a bit of a shapeshifter.
Yeah.
And there have been studies that show it helps with constipation, and it paradoxically, it also helps with diarrhea. So I think usually if somebody swings in one direction, constipation or diarrhea the other, I usually tell people to just give it a little bit of time to kind of let their bodies normalize and kind of acclimate to the fiber.
So it seems like that would be a good choice perhaps for someone with an IBS mixed type.
Yeah.
They're kind of fluctuating between the two.
Yeah, like, it's funny in IBS, there was this study that came out in the Red Journal, which is like it's like the American Journal of Gastroenterology, it's like our big journal in the field. And so the study was like, what are the number one recommendations that people are making on TikTok for IBS? And fiber's like not on that list, I find. Like people tend to recommend abdominal massages and probiotics for IBS. And I think sometimes the basics like fiber is like very well studied for IBS. Either ideally in your diet or through a supplement. Some people with IBS go on this diet called a low FODMAP diet you've probably heard of. And that's something that can help some people identify
we trial
triggers.
It sometimes with our patients.
Yeah, and it helps. Like sometimes people pick out triggers.
It can be limiting sometimes, especially when people have specific cultural diets.
Totally. Yeah. And I like, and this could be because I see a lot of people who like, I'm like, we're a tertiary center in Boston, but like I often end up seeing people who have been living on that really restricted low FODMAP diet for months. And, like one thing I always try to remind people of is that low FODMAP diet is not a long-term diet. It was never meant to be a long-term diet. So if you're living that way and you're like, but I can't do anything outside of it, you definitely need to talk to either your doctor or get another opinion because you can't meet your nutritional needs on that diet.
Yeah. Yeah. It's really tricky. And I'm curious, what bit of misinformation are you seeing in the IBS community? Because this is a diagnosis I've seen patients get as a result of perhaps not making a diagnosis.
Yes.
And it becomes like not a diagnosis of exclusion, but almost like a catch-all diagnosis or a punted diagnosis where someone doesn't know what to say. They put IBS as the reason. And being family medicine, I have a little bit more of a holistic view of things because I'm treating so many different ailments in their body as well as their mental health. The amount of time that I see a comorbidity related to anxiety, depression, and IBS is super interesting to me. And I'm curious, in your line of research, have you seen perhaps the nervous system that's in our GI tract that is influenced perhaps in our neurotransmitter function in the brain play a role also similarly in the gut and how that's connected?
This is my favorite topic in the whole world. So I'm so glad you got into this. I think you're right that when somebody gets diagnosed with IBS, it feels like such a disappointment for the patient because the patient hears, I think often, we don't know what's going on when you say it's irritable bowel syndrome. First of all, like that name, irritable bowel syndrome, like is so fraught for so many reasons. But also, I think even the doctors, the way we diagnose IBS is this like set of clinical criteria, which by definition means your tests are all normal. Like you have to have normal tests or it can't be IBS according to our criteria. And eventually, because there's a lot of comorbid anxiety and depression, I find a lot of patients end up hearing it's all in your head. This is all in your head because there's nothing wrong in your gut. We've done all these tests. They're normal. We know you have anxiety and depression. We know there are studies that show things like cognitive behavioral therapy or antidepressants can help with your gut symptoms. And when all that comes together, the patient just feels like nobody believes me or this is all in my head. And they keep getting told you need to de-stress or get these psych treatments. And if I'm being honest, that's what I think a lot of medical students and residents learn too. Like it wasn't until I was a resident that I finally like really dove into the literature and learned that there are dozens and dozens of abnormalities at the level of the enteric nervous system, which is the nervous system in the gut, that are different in IBS compared to people who don't have IBS. For example, this is like just one of many. There are microbiome changes too, but like
the baroreceptors and how they perceive pressure.
Yes, exactly. Like the nerve cells, because the gut has millions of nerve cells, just like our spinal cord and brain, those nerve cells react at a lower threshold than people who don't have IBS. So we will perceive normal changes in pressure from digestion, from food, from stool moving along that other people either don't perceive or just perceive as normal. They will perceive this as very uncomfortable, and that can be measured. And that's, we just don't do those. We don't do those stains on the kind of regular biopsies we get in colonoscopies. And two, a lot of the pathology the enteric nervous system is in the deep muscle layers of the gut. When we do a colonoscopy, we're getting this like superficial biopsy, just like on the mucosa, the top layer. It's not necessarily going to reach where a lot of that pathology is. But once I realized like there are abnormalities, you would totally change your perception of the patient sitting in front of you. Just in the way that like in my field in GI, if we have a patient with inflammatory bowel disease who comes into the ED and they're saying, I have 10 out of 10 pain. And then we have a patient who comes in who says, I have 10 out of 10 abdominal pain. They have IBS. When we scope both of them, we do a colonoscopy or an upper endoscopy, and we see the patient with IBD has bleeding everywhere and there's inflammation and it looks so horrible and uncomfortable. We immediately feel sympathy to that patient. And we say, my gosh, there's something so wrong here. And we have all these treatments that can help you and we're going to get you better. We go in and scope this other person who has saying they have the same amount of pain, but everything looks normal. We take the biopsies, we're like waiting, they all come back normal. Those people don't get that sympathy. They don't get that like,
well, it's like an invisible illness, right?
Yeah. And on top of it, we don't have 20 pharmaceutical companies who have come up with these brilliant treatments for them. There's not even like a race for the cure, right? For some of these like disorders of gut-brain interactions is what I treat. And so it can just be really isolating, difficult. So I think like one of the big myths about IBS that I try to combat every day is that it is not all in your head. Usually the conversation I have with people, and there's different degrees of IBS. There's like kinds of IBS that you can manage kind of with some simple dietary changes. And then there's really more intense cases. And that's probably with the kinds that I end up seeing. But usually the conversations I have start with me saying, one, I know it's not all in your head. Two, even if your tests are normal, I believe you that your symptoms are real. And I know there are abnormalities, whether or not the tests that we have are reflecting them or not. Because of all the tests that we've done in research where we've done these full thickness biopsies of the gut and researchers have tried to understand that. I try to also tell people there are hundreds of companies out there who will sort of like prey on your vulnerability and wanting testing abnormalities. Like you want
and for the fact that the healthcare system has written you off and made you feel like it's all in your head.
And then you get this company that will say like, exactly, like you know, we have this set of testing. Maybe it's food allergy testing. Maybe it's microbiome abnormal, like something. And for however many hundreds of dollars, we'll do that test and we're going to show you what's wrong. And then the tests come back and like often there is something that the test is flagged as not being normal. I try to tell people that those tests that are these third parties, they don't necessarily change what we do. They can point out abnormalities that may or may not be clinically valid, that may not correlate to the pathology that is actually underlying the issue. But the good news is that we have a lot of treatments. I think we just haven't done a good job of like advertising what they are, of like making people aware. Some of those treatments are very natural. They're diet approaches, they're physical therapy approaches.
Well, walk me through the sort of hierarchy of if you're starting from a mild case and you're making dietary recommendations to whatever your big guns are, your vancomycin.
My gosh, no.
No, but I mean in terms of antibiotic treatment.
Yeah. Diet is often the first thing. So people with IBS, and again, you are right to say that IBS is this word that catches dozens of different kinds of pathology, which is kind of the challenge of it. Mm-hmm. But it means that some people are going to respond to changes in diet. Some people are going to have different dietary triggers than someone else who is equally labeled IBS, but they're just dealing with very different things. Mm-hmm. So sometimes it's changing their diet. Sometimes it's a low FODMAP diet.
But you said they shouldn't be on that long term. What would be a solution long term for that individual?
What we want.
Reintroducing individual.
Yes. Yeah. So with the low FODMAP diet, what you're supposed to do, and this is why I don't like when people go on these without a registered dietitian, like watching very closely, because I too often see people just restricting for the long term. But what should happen is maybe for about 2 weeks, you cut out everything that are in this group of FODMAPs, the FODMAP, each stand for a different food group. And each of those 6 food groups are kind of known and studied to have been triggers in people who have IBS. If after the end of those 2 weeks, you feel a lot better, it tells me that there is something in one of those foods that is triggering your symptoms. if you at the end of those 2 weeks actually don't feel much better, we can stop the experiment right there. Like we don't have to, do it. It tells us food's maybe not the problem, or food could be the problem, but we need to approach it a different way. If you feel a lot better, then we systematically add back in those food groups one at a time. And then we say, okay, we've added back in the F category. And now we keep a food diary. We say, how do you feel over the next week? And if objectively you still feel pretty good, great. It means that food group is not the problem. Then we add in the next group. And then suddenly you feel worse. Then we say, okay, this is helpful. There's something in that O category that we need to pick out. And so ideally, it would just be one or two things that we find. And that's often the case. Maybe it's onions. Onions and garlic are the secret ones, right? When you find what those one or two things are, you can liberalize your diet again. You can eat things that you previously might have restricted yourself from eating because now you've picked those two things. So it shouldn't be this long-term thing. It should just be a tool to find maybe just a couple things that are the triggers. For some people, and what's interesting is, food intolerances, they're very different from traditional food allergies, right? And there are third-party tests that will tell you if you have these kind of non-traditional food allergies like I'm talking about. And so people will come in because the low FODMAP diet's hard to manage, and they'll get these companies, they'll be we'll do this blood test and we'll tell you what the problem is, and they'll be look, I got this result and it's horseradish and it's cabbage and it's these things. And I'll be maybe it is, maybe it is. You tell me, did you stop eating horseradish and you felt better? And they'll be oh no, I used to tolerate it in the past. and it's well, wait a minute. Then that's not necessarily telling us anything. But there is this study that I think about a lot, and I don't know how to know if it applies to the person sitting in front of me every time, but someone might come in with IBS and they have totally, they'll get they'll go to an allergist, they'll have totally normal food allergy testing. But they did this study, I think it was 2021. It was by these neurogastroenterologists in Belgium who are our colleagues, and they do really good work, and it was published in Nature. And they basically found that in a small cohort of people with IBS who would just have met criteria for IBS, if they were to expose them to the antigens in different classic food groups, maybe it's dairy, maybe it's gluten, maybe it's shellfish, things like this, that they didn't actually have a formal allergy to, but during the endoscopy in this research study, they sprayed this slurry of shellfish on their mucosa, which normally we don't do, right? This is a test we don't do in real life because we always tell you to fast before your endoscopy. But they did this in the research study. They were able to see, they took videos that for some people with IBS, and was the case in this study, they would have these kind of wheel and flares we see, an allergic reaction to certain types of food triggers that you would never have caught because you weren't looking. Yeah, you would never see it on a blood test. You would go in, during a standard endoscopy after they've been fasting, you'd never see that because you just weren't looking at the right time. But they were having a reaction that we think could be mediated by just local mast cells. So not causing this big inflammation in your bloodstream, but by mast cells that are just in the gut. And sometimes those people actually respond well to mast cell inhibitors, which, if you had just done a blood test, you would never think to try those on. So sometimes you don't have to cut out the food groups, but you need to kind of think about medicines that might address what those foods are doing to you. Again, sometimes we don't have the perfect test in a clinical setting, and it can be a little bit of trial and error. But anyway, food is the first thing that we think about. We try to see if there's certain food triggers without telling someone to eat so restricted a diet that their life is miserable.
Yeah.
There are also
before you move on, I'm just curious. For those clinicians who do sell some kind of kit to get these answers, do you feel like what they're doing is unethical?
Yeah, I think anybody who is profiting off of a vulnerable patient who's looking for answers, where they knowingly know the data isn't there, I think that's completely unethical. I think that there's a difference probably this is a very different thing, in doctors who are trying to think outside the box and trying to think of ways to help patients, where they're not profiting from it. Probiotics are another sort of top thing that patients think about. Sometimes doctors recommend probiotics themselves. They're not making money off of it per se. They're just go try it, right? I don't think that's unethical to try because I think the doctors want to try to give an idea to a patient. And I think probiotics are really tricky because first of all, patients tend to think that gastroenterologists in general love probiotics, right? Like it comes as a huge shock when we say, actually, formally, the American Gastroenterological Association, we don't recommend probiotics. It's a big surprise sometimes because the marketing...
Well, outside of specific uses.
Yes, for most indications.
Hyper-specific.
Yeah, like pouchitis and IBD, we do.
Sure.
And there have been a handful of randomized controlled trials, a handful, that show it may be beneficial in IBS, but then when you look at the data on aggregate, when you do these meta-analyses, it's not great. So we don't recommend it formally. That doesn't mean that when a patient comes to me in my clinic and they say, I tried this probiotic and it's the only thing that worked, like my bloating went away or my pain went away, that doesn't mean I think they're lying. I don't think that at all. I think one of two things. One, I think they got really lucky, which is wonderful. They found they were the right phenotype. They found the right formulation, the right strain that happened to be what they needed. Maybe it's the placebo effect, could be the other possibility. Usually, regardless, I'm happy for them and I move on with my life. They move on with their life and they live their best life.
So I like putting myself in the shoes of the listener or viewer. And in this case, it's someone who's experiencing unusual abdominal symptoms, hasn't really gotten a diagnosis, is considering spending their limited healthcare budget on a probiotic.
Yeah.
And historically, I've said on the channel, similar to this statement, that we shouldn't be using them except in very specific instances. I don't like doctors who sell them. I've called them out publicly on the podcast.
Yeah.
But then when we say something like, maybe by chance you got lucky and it worked, isn't that person just thinking, what if I'm the lucky one that hasn't tried it yet and I should try it?
I think that...
Back to the interview in just a second, but first I want to tell you about Microsoft Dragon Copilot, an AI clinical assistant built to simplify and transform the way care teams work. I've needed something like this since I started practicing medicine. Dragon Copilot can ambiently capture conversations and orders at the point of care with patients and automatically converts them into notes. From there, you can ask the app questions and receive responses drawn from those notes and your favorite third-party medical references, all with clear citations. It can summarize clinical evidence and even generate referral letters and after-visit summaries. This allows doctors like me to spend more face time with our patients instead of computers. It's about time. And it's not just for family medicine doctors. Dragon Copilot is customizable for a variety of medical professionals and specialties, whether it be nurses or radiologists. Not only does it help keep your data safe, but Dragon Copilot also supports you in meeting the ever-evolving world of regulatory guidelines, which can be a huge headache, believe me. If you're curious how this plays out across an entire clinic day, download the Day in the Life guide below. Oh, and Physicians Week is coming up, so it's a good moment to recognize the impact clinicians have on their communities, in clinics, hospitals, and everywhere in between. Microsoft's goal with Dragon Copilot is to make the day-to-day work lighter so we can stay focused on care. All right, let's get back to the interview.
Yeah, I think when you're hurting and you're suffering, like you want to believe you're going to be that lucky person. Mm-hmm. And we also know the placebo effect is real. Like we know that some people are going to experience a benefit, but that is not maybe sustainable. And that's not necessarily due to like physiological changes in the gut. They may be due to changes in the brain. That's not, however, the vast majority of people who come to my clinic are not people who say, I tried this probiotic and I got better. Yeah. It's the vast majority, they're on a probiotic, or some are on probiotics, and I say, hey, but is this helping? And they'll be like, well,
no.
I
now
don't
that
know.
I evaluate
yeah,
it,
or now that we're thinking about it, like, no. And if that's the case, then I think that's a good opportunity for us to look at the data and just say, like, the truth is the data is not as hot as it seems like it is when you're walking down the supplement aisle. And I think if it was, like, we'd all be on a probiotic. There's also a lot of people who take probiotics who don't even really have symptoms. They just take it because they think it's good. It's good for gut health, right? It's just been marketed as like, can't hurt, might only help. And like, they somehow think they're optimizing.
Well, they treat it like the gym. Like they're not using it as physical therapy. Yes. They're like, I'm just going to get better with this.
Yeah. There's only upside to this. And I would argue that, like, truly, I think the downside of the probiotic supplement industry is that we neglect probiotics through our diet. Like if we could all optimize, like there's no GI doctor who who would disagree that we need more probiotics in our diet? Right? Exactly. We all want that. And we want that for our patients. Like, but we're not probably all getting that, right? Like when we talk about probiotics in our diet, we're talking about like maybe obvious choices like Greek yogurt, for example, is like a good one. First of all, Greek yogurt, I love Greek yogurt. Yogurts sometimes like, you have to be very careful when you pick a yogurt too, right? Because a lot of them are ultra processed. They have like a lot of added sugar. You have to kind of, it's not as straightforward as it could be. But besides that, it's like fermented foods, right? Like we love fermented foods in GI. Well, a lot of people like take time to come on board with the idea of eating more fermented foods.
Yeah.
It's so much easier to just take a capsule or a pill if you think they're doing the same thing for you when they're not. And
what about the fact that some of the yogurts are, let's say, pasteurized,
yeah,
and then they add the cultures in after the fact? How different is that than taking the supplement?
Well, there haven't been, to my knowledge, any head-to-head trials of like Greek yogurt in that form with the supplements. Usually the trials are done like supplements versus nothing, like placebo, like empty capsules. But what they do often find is that if it says what it should be, I should say, if there are live cultures in the yogurt, that's supposed to be the beneficial part. Like, so what the problem is that a lot of, when it's in capsule form, the live cultures are dead. They're not actually like living by the time they enter your body. They're not reconstituting anything in your gut. I mean, the big problem about microbiome directed therapies that you can just buy in your grocery store is that despite what I think some companies are currently saying, we don't actually even really know if the microbes that we associate with certain disease states are the cause or the effect of that disease.
Sure.
We know that there's a lot of associations with some bacterial strains seem to be upregulated or higher in certain diseases that we don't want. Those same bacteria seem to be lower in disease that we do. Like, so it doesn't always add up. And sometimes I tell people like, your gut microbiome, it's like this garden, right? And what you see sometimes are the flowers or the weeds that are growing there. And you think to yourself, gosh, there's all these weeds. Like what I really want are these flowers because they seem to be associated with happier people, healthier people. And you can maybe pull those weeds out and you can sprinkle some probiotics, like some nice, lovely seeds for beautiful flowers. But if the whole problem here is that the soil's pH is wrong, that you're like not getting enough sunlight to that garden, it doesn't matter what you're messing around with the supplements and the probiotics. You need to change kind of the underlying issue here, which is the prebiotic part of it. Potentially that could be it. Like maybe you're just not getting enough nutrients in your diet to support the growth of the right type of flowers or microbes. So I think we've oversimplified, we've monetized the probiotic industry in a way that has just gotten eons ahead of the science. As a gastroenterologist and as a scientist, I think the microbiome is one of the coolest frontiers in our field. And I hope and I think in the next, if I'm being optimistic, decade, probably longer, we will have microbiome directed targeted therapies for each person where we say we have an effective way of understanding what your microbiome looks like and we know exactly how to change it for you. We have the right way to do that. We don't have that today. We do not have that today. Like even fecal microbiota transplant, FMT, which is probably, the most intense, in-depth way to change someone's microbiome, doesn't work in so many indications. Like the numerous meta-analyses have shown it doesn't work for irritable bowel syndrome. It doesn't work for Parkinson's disease, which is what I study. There was a big meta-analysis in JAMA about this. As you've seen, it works really well for C. difficile infection.
For sure.
Right? Like, but that's so narrow. And it's a very specific situation happening in C. difficile. But,
right.
And so like, what hope do we have by ingesting this capsule of dead microbes and like hoping it makes its way all the way down into our colon? It's very little.
Mm-hmm. So ultimately, when patients come in, you discourage probiotic use?
I don't rip it from somebody's hands if they believe that it has made a big difference to them. But I'll tell you, like, that's also just not usually the case for someone who's come to see me. I don't see that. I also, if somebody's spending a lot of money on it, and they're like sort of on the fence, I try to think about, well, what are the other things that have been slightly better studied or even greatly, like far better studied than probiotics that we can think about. And sometimes I think what the appeal of probiotics is in a way that it feels natural, right? Like in gut health, there's a lot of people, and this is actually not just true of gut health, it's true of all of medicine. People want a natural solution to their problems that don't involve a medication per se, or something that we call a medication. And that's why changing the diet when possible feels very alluring. And I think that's also why probiotics feel very alluring, because it feels like something natural you're taking. Oftentimes the answer though is a medication. And sure. and we have a lot of, what I think people don't appreciate is that you might think from what you hear online, or even from what your own doctor tells you, because this is like a subspecialized field. Neuro-GI is like not even just gastroenterology, it's like this special thing. There are a lot of medications that target the enteric nervous system that we have that you just might not have thought to use, might not have heard of, or you've heard of them, but in the wrong context. I'll give you an example. Like we often in neuro-GI use medications that at one point in time were developed as antidepressants. Like we use things like tricyclic antidepressants, which are not very good antidepressants anymore, but that when they were developed, they were thought to help with depression. They're kind of weakly, they have some of those properties, but what we discovered in GI is that maybe they're not so fantastic at affecting our central nervous system, but they're very good at increasing the threshold at which the nerves in our gut respond and react. And so it can take somebody who responds so easily to triggers within their body to send off these messages that tell their brain they're in pain. It just raises the threshold, these medications. And so those nerves are not responding to every small gurgle, every change in pressure and distension. You have to be very careful, I think, when you talk about these medicines, that you don't present them as like well, the real issue here is your stress and your anxiety. And this is a medication that's going to treat your, it's what we're really trying to do is treat your depression. Sometimes you have to, and as you should, you have to go through the whole kind of physiology of how these things work to help people understand that you're really targeting the gut more than you're targeting the brain. But it's a longer discussion and there's like a lot of nuance to it. You often just don't get that in a rushed visit.
Yeah, that's tough to get into a 15-minute visit.
I know, and you're just trying to check someone's blood pressure. And
So we started with the diet. What's the escalation of care after that? Perhaps tricyclic antidepressants and amitriptyline, anything else?
Yeah, it depends. Yeah, it depends on if you have like more diarrhea, more constipation. There are a lot of medications for constipation, like over-the-counter laxatives that people usually will have tried by the time they come to see me.
Like a Senna or something.
Yeah, Senna or Miralax.
Yeah.
Colace is kind of a placebo.
Yeah.
It's been shown like in a lot of our randomized control trials to not really do too much.
What about in combination with Senna? Because that was the cocktail that we would use inpatient quite often.
Yeah, I usually, if somebody has like 20 medicines on their list, I just take Colace off.
Interesting.
Because it's not giving you much bang for your buck. Senna is pretty effective. And Senna is like a stimulant laxative. It's effective. But there are people who, very commonly in IBS, they won't have responded to most of the stuff you get over the counter, right? And then they're struggling. And then they say, but I have IBS, so there's no treatment. And actually, there's lots of different prescription medications that treat not just the constipation, but most importantly, the pain and the bloating that go with IBS. That's like kind of what makes people extra miserable. And you might have seen some of these, like linaclotide or prucalopride is another one. Like, but there are all these medicines that like the average person isn't talking about because
is that Linzess?
Linzess, yeah. And they're there and they show that they work very quickly to relieve constipation in the first couple of days. Like, so they're very, very good laxatives. But then the clinical trials have shown over 8 to 12 weeks, they can help kind of rewire the system to help with bloating and help with the pain. And so I like those medicines for people who not just have constipation, but have a lot of the discomfort that goes with it. And they're great. Like they're easy to titrate. You just kind of need a doctor to help you get there. And you don't get some of those neuromodulatory effects, neuromodulating meaning changing a little bit of the threshold at which those nerves react through diet alone, or it can be really hard. I think that a lot of, you mentioned the enteric nervous system. The enteric nervous system is creating neurotransmitters very similarly to how our brain does. A lot of those can be influenced by what we eat, and then they can be influenced by how our microbiome processes what we eat. And there have been some limited studies that show, epidemiological studies mostly, that show that eating a certain kind of diet, whether it's the Mediterranean diet or like a more anti-inflammatory kind of diet, can help with chronic pain and IBS and these types of symptoms. But I often find that you need both. You need the diet part of it. Some people just will benefit from the medicine as well. And I don't think there's ever really any shame in that, in needing to get the help that you need. It just, people want the natural way with the probiotics. And I get why that feels more natural. But when you then sort of realize, wait a minute, it's like dead bugs, suddenly that feels a little bit less natural.
Yeah. Yeah, that's tricky. Have you heard the information coming out recently that younger and younger people are getting colorectal cancer?
Yeah.
What are your thoughts on that?
Yeah. This is probably one of the biggest medical mysteries of, I think, our time in GI. It's something that we're thinking about all the time. I've probably made a handful of colorectal cancer diagnoses myself during colonoscopy in the last year on younger people. More often, fortunately, what I see are the polyps. What we know is that there is this trend in younger people that's a real trend, where younger people, meaning under the age of 45 or 50, depending on how the study was done, they're getting diagnosed at higher and higher rates with colorectal cancer. Meanwhile, older adults, those rates have been falling, which we think is probably due to screening uptake. We used to, I think, like when I was in medical school, I used to think of the big risk factors for cancer as being smoking and then like your genes. And obviously we've been smoking a lot less as a society with every generation. And our genes themselves haven't been changing, although I think our epigenetics can certainly be changing. And this is something I've written a lot about for the Washington Post, but most of the oncologists and experts that I talk to sort of all agree that it has to be something in our environment that's changing. And I think what I've come to appreciate is that there's no like one smoking gun here about what it is, but I do think it's a confluence of a lot of different factors. I do think diet is a big part of it. I think the other thing that I've come to appreciate, which is pretty sobering, is that a lot of our risk for early onset colorectal cancer, the groundwork for that starts to get laid when we're really young. It's early childhood factors that often we don't have that much control over. There's this classic scenario that's tragic that we see patients all the time who will say, like, I did everything right. And they did kind of do what we might say is everything right. Mm-hmm. They're fit, they eat healthy, like all these things. And I try to, sometimes when I'm explaining these cases to my patients or to the public, with cancer, what we see is the end result. We see when someone gets cancer, doesn't get cancer. And I think about cancer risk, like sometimes I try, the analogy I use is like you're building a tower with a stack of blocks. And when somebody gets 10 blocks, they get cancer or they don't if they never hit that threshold. But some people are born, maybe it's their genes or maybe it's their early childhood. They have like 9 blocks by the time they hit adulthood stacked against them, right? Like we know there are these risk factors from epidemiological studies, like drinking sugar-sweetened beverages has been associated with early onset colorectal cancer. Sedentary lifestyle, ultra-processed foods, some of these things. Maybe some of those things were part of their lifestyle before they even really remember what. Like right now, today, if I were to ask you, like, Mike, when you were 7, how many hours of sunlight did you get?
Got a lot of sunlight, but I also got a lot of 2 liters of soda.
So. Yeah, right. Like, and sometimes it's hard to quantify. Yeah. Like you might be like, yeah, I drink 2 liters, I think, like, on average every week, or was it every 2 weeks?
Every
or was
day.
it every 3 weeks?
That was my hydration. So
I used to drink a lot of Capri Sun, if that helps.
Okay, yeah.
And so you might actually like have more blocks stacked against you than it seems to the outside world than you even know. And then you say like, well, then it takes very little for you to hit that threshold. And then somebody else, like seems like they've done all the wrong things. And I don't even like that label, but they'll live at 7 blocks their whole life. They'll never get cancer, but you'll look at them from the outside and you judge. So I think, one, it's important to not judge anybody for, and certainly never to blame somebody when they have cancer. Because that's the first thing that a patient does. When I tell them you have cancer, they say like, why me? Like, what did I do? And it's never so black and white as what did you do? This is like a really hard topic.
Of course.
But I also think it's important to remember that we do think 40 to 50% of our risk factors for cancer can be modifiable. So it is a helpful conversation not to blame anyone or ourselves, but to say, okay, these are the risk factors that we think are associated. Maybe I'll make some changes going forward that will help me lower that risk. We won't eliminate that risk. We can't do that for anyone, for any disease almost, but it might help us lower that risk. And so, I mean, one of the biggest ones is probably ultra-processed foods and how much ultra-processed foods we're eating. I think ultra-processed foods there are certainly inherent chemicals and additives and problems with the foods themselves. But I think for me, the bigger thing is like what we don't get when we fill our diets with ultra-processed foods, and that's fiber. Fiber has just been known to be so protective against colorectal cancer. But it's also, like you said, eating a whole food diet, one that is filled with lots of different nutrients from different plant-based sources. Those are the kinds of diets that the studies have shown are probably most protective, more than just like a fiber supplement per se. So I think changing how we eat is like an important big part of the conversation. It's also I see whether we're talking about cancer or something else, changing how we eat is one of the hardest things any of us can do because it's so linked to our culture. It's linked to our pleasure. It's like part of who we feel we are. So it can be really hard to tell somebody like, I want you to cut down your alcohol, or I want you to cut down how much red meat you're eating in a week. So sometimes I say an easier place to start is rather than saying like, here's all the 5 things you should cut down. You could do that, but maybe think about what are you going to add? Like maybe at dinner, just think about, I'm going to add 1 more serving of vegetables, or I'm going to eat like 1 more serving of beans this week. And even like a small thing that you're going to add that's good for you, rather than starting by taking things away, can be like that gateway into eating a little bit differently.
Unique swaps. Like I found a great way to get some fiber in is I switched over to a fiber pasta, and I've experimented with different ones. The classic chickpea, edamame.
Edamame pasta?
Yeah, mung bean.
Oh, I love a good mung bean.
Mung bean pasta is not for the weak because it's like a 40-gram dose of fiber in a single serving.
I think legumes are like, so underappreciated.
Yeah,
I actually don't know where you get mung bean pasta. I eat mung beans like
I'm sure it's sold
own.
in supermarkets, but I'm a big Amazon shopper. So yeah, mung bean pasta was a great hack. There's even just classic spaghetti that is fiber rich. I think it's called like fiber spaghetti.
Yeah.
And I feel like that's a great way. And I know some people like to do the protein fiber pasta. I don't like getting my protein from pasta because I'm already consuming a protein as a meat eater.
Yeah.
That I'm like doubling up on protein and getting 100 grams in a meal is not very valuable.
The protein, protein is like the new, like, I don't even know, like everything's got a little added protein.
Yeah, protein water now in Costco. Isn't that wild?
Protein water?
Yeah.
How do you do that?
That's what I ask. I don't know. What is, to me, it's like, that's just a shake.
Amino acid, like I don't know.
Isn't that
thick?
a shake? No, it's thin. It's water.
Fascinating.
Yeah. Sam, we got to get it, by the way, because we reacted to it, but we never purchased it. And we should.
Oh, yeah. You should taste it.
We should taste it and see what it looks
What
like.
if you love it, though? You might accidentally sell it.
Well, who knows? It doesn't hurt. So, yeah, that's an interesting way to get people to make healthier swaps. I know people were encouraging that for meat substitutes. But fiber substitutes, I think, is a little bit easier. So.
Yeah. The meat substitutes, we eat meat in my family too. We tried for a while, like this was like a couple of years ago, we were like, let's eat more of the meat substitutes, like for taco, like we do Taco Tuesday.
Yeah.
Big hit in my family. Eventually we kind of like got turned off of it a little bit too, because I think even some of the like highly ultra processed meat substitutes, I was like,
they're also junk food
like
still.
they weren't actually like probably like I was making like a win in one category maybe, and then like maybe I was taking a hit in another category.
I think even the types of meat you're consuming, you can have a much healthier meat. Like I found an amazing thing because I was looking to lower my saturated fat intake. My cholesterol was quite high.
Yeah.
And I found a type of bison cut that was in a serving, 6 or 7 ounces, I forgot what the number was, 1 gram.
Oh, it's really low.
Super low. And I'm like, I couldn't even believe it was real, but it's so valuable to get a lean piece of meat because you're still getting all of the iron, the B12, like the things that you'd be concerned about. And you're not raising your cholesterol as much as you would be otherwise. So, because otherwise people think, oh, let me get a fatty ribeye. That's not necessary.
That's like the only way. It's in the world of colorectal cancer. Actually, I'm glad you brought this up because there's 2 degrees of meat eating that tend to polarize people. Like I think almost everybody agrees that processed meats probably have the strongest data to being linked to colorectal cancer. And those are things like the hot dogs or cured meats and stuff. I often get a lot of pushback when I talk about red meats in general being linked to colorectal cancer. And, I think this is like worth exploring because red meat, I think we don't have all the data yet about what it is specifically about red meat that's contributing to the cancer risk.
Right.
So I think for me, I'm convinced enough by the data on red meat that I think most of the epidemiological studies seem to indicate that more than 3 servings a week is linked to a higher risk. And there are a lot of people who are eating so much more than that I think even like a little bit of cutting down helps. What I think we don't know yet is it something inherent about the red meat itself that's the problem?
Or the type of red meat we're consuming.
Yes. Or is it the type
or how we're consuming it without
the Maillard
marinades?
reaction with or without marinades? Yeah. Is it, but I often because I write about this on the Post, I've done reels about this. Like I get that red meat is like a big part of our American culture. So it is like, it's hard to tell people like, it's the cookouts, it's the stuff that you love to eat when you're gathered with your family and everyone's having a great time, that stuff could be harmful. So I often get a lot of pushback that's like, it's not red meat. It's the fact that you're not eating organic grass-fed beef. When you eat organic grass-fed beef, there's no cancer risk. Like, there's no data that makes that will make that true at this point. But I do believe that like there's probably healthier ways to eat the red meat to lower your risk. But as we're eating it today, the way we can do these epidemiological studies, we haven't gotten to the point where we can like really slice down the, like a year ago, what temperature was your grill? Like how did you marinate? How many
open flame or not open flame?
Yeah, we don't know that. So I think the safest thing I can recommend to somebody is to try to eat no more than 3 servings a week in whatever way it is that you're making it right now. And there are studies that show, like you mentioned, marinating your meat can, in theory, prevent some of those carcinogens locally from forming directly with the proteins from the meat. So that could be protective. We're probably not at the stage where I can tell you, if you marinate your meat every day,
this is the percentage.
You'll never get cancer, or your cancer risk will be, halved by like whatever percent. But there are ways to make it better, and there are ways to keep eating meat in your diet.
And we also have to remember when we say, by consuming 3 times or X number of times per week, your number goes up by having colorectal cancer by 19% or 20%. Absolute versus relative risk, what that actually means, big picture in comparison to all the other things going on in your life. Like how well is your cholesterol managed is probably going to be a way bigger factor for that red meat consumption.
Yeah, and is this the hill that you personally want to die on? That's like a very personal choice.
Right. So, because in family medicine, I'm pulled by specialists in so many different ways because of the organ they're looking to protect and serve.
I bet.
And I'm like, hold on a second, there's a person in front of me. And while yes, I want to reduce their red meat intake, but it's not because the red meat raises colorectal cancer by 19%. It's because their cholesterol is also really high. Their family history of cardiac disease is high. They have a higher risk for Alzheimer's because they did genetic tests. So I think about it broadly.
Do you, as a family medicine doctor, do you find that you're seeing more people uptake the screening in that 45 to 50 range for colorectal cancer screening?
Well, whether they choose to uptake it or not, we kind of like force them into it.
You were recommending it.
In the sense, I recommend it, and we have such a good relationship that I guess everyone goes for it.
They follow through.
Yeah, exactly.
That's great.
And we also have really great screening protocols in our hospital because we're an academic institution. We have residents. We have free options for people who are charity care. It makes it a lot easier to get this stuff approved and done. So even from like a scheduling perspective, we have like open access scheduling where they can direct schedule.
Oh, it's the best. Yeah, I do a lot of open access.
Yeah, exactly. So that makes it easier. I will say with some of the non-colonoscopy screening options, people do get excited about those for those who have fear of sedation. But to me, I always try to avoid that because there's limited things you can do in terms of prevention by getting the polyps out and being more preventive in that way. So
yeah, I mean, I think like a lot of the conversation about early onset colorectal cancer is about changes you can make in your lifestyle and diet and changes. But I also know that, I forget the exact statistic, but a good portion of patients who were diagnosed with early onset colorectal cancer, so like before the age of 50, we could have caught that case earlier if they had gotten screened according to just age appropriate guidelines based on a family history. You know,
like the 10 years prior.
Yeah. Like, first of all, I think we like not enough people in that 45 to 50-year-old category are getting the screening. Like, we're all so worried about the rising kind of number of cases. But then I think when it's our turn to go get the colonoscopy, like we're a little shy sometimes.
Okay.
But the number of people who I sometimes come to my clinic and we're deciding like, when are we going to get the colonoscopy? Like, what are their risk factors? And I tell them like, well, tell me, you know, who in your family has GI issues? It's actually like pretty common. I mean, and I think I know this from my own family too. Like they'll say like, I think my uncle had some kind of cancer, you know, like they don't know exactly what the cancer was. And then maybe the like most important question is how old were they when they got the cancer? Nobody knows that stuff, you know? And like, you know, to be honest, like, do I know that for like a lot of my extended family? But it makes such a big difference.
Do you think if we were to parse out that data, obviously you'd be hypothesizing here, but would it bring the numbers to a less scary increase than what we're seeing now?
If we were to have caught the people who
Meaning if we were screening the people that were needed to be screened.
I think they have parsed these numbers, and most cases are not genetic that are contributing to that rise.
Got it. Okay.
So what we would be catching are the genetic cases, but those are actually not the majority of cases. But there's still cases that are preventable, and like any portion of that puzzle that's preventable, we have to try to hone in on.
I function in a weird space because I work at a community health center, but I also spend time in their private clinic in the hospital system. And being that I'm in the media space, I have a lot of people that come to me asking questions. So I have this world where people need care and they can't afford it, or they have difficulty getting access and they need their colonoscopies. But then I also have some of my friends that are in their 30s. They're like, I heard this on the news. I want a colonoscopy right now. And I'm like, bro, you do not need a colonoscopy. Trust me.
Delightful as it is.
Yeah. Like, there is no need for this. So what do you do when a patient comes in really excited about getting a colonoscopy, but clearly doesn't need one?
Yeah. I love when people are excited to get a colonoscopy, but it's true. And I actually will say, like, I think the discussion about the rise in cases has made a lot of people want to just get a colonoscopy, even if they don't necessarily have any of the symptoms. I get that tension because I get that the signs are often really subtle. Like, we think of the signs traditionally as like rectal bleeding, right? And that would flag almost any doctor to say, yeah, we've got to look, we take that really seriously. And so like, if anyone's listening who has rectal bleeding, like, do not brush that off at all. But sometimes the signs are more simple. They're like just a unexplained abdominal pain. Yeah. Like it gets like thin caliber stool or maybe looser stool. Like it can be diarrhea. It could just be some bowel habit change. That's so vague. And I think often, of course, people with irritable bowel syndrome are like, it's me. This is what happens to me all the time. I have these changes. And how can I be sure it's not cancer? And I do think that's where having a good, close relationship with your doctor that you trust, who trusts you, is important. I obviously don't give out colonoscopies to everyone who wants them. People, you know, they don't meet the criteria for them. But I've also become a lot more thoughtful than I was 20 years ago. Like 20 years ago, if someone was young, came in, and they didn't have rectal bleeding, like cancer wouldn't have been on my mind, right? Like when in my early days of med school, because this rise, it was starting then, but it like wasn't on the forefront of people's minds. And it is really scary how some of these early cases can be missed, and people, you know, we can say they got dismissed by their healthcare providers for some period of time, couple of weeks. But it's also, I think, just because the healthcare providers aren't thinking cancer is just not even on their minds for a young person.
Yeah.
It's now on my mind for a young, for somebody who's coming in their 20s, 30s, 40s, certainly.
But in those scenarios, it's a diagnostic colonoscopy. You're seeing some symptom that's warranting them getting it.
Totally.
But I'm talking about the examples of people coming and asking for a screening.
But otherwise feel fine.
Yeah.
Got it.
Like the worried well population, which I have a lot. It's almost like the biohacking population who want their full bodies MRI'd every year.
Right.
Like that kind of.
Yeah.
And I feel like we fueled a lot of health anxiety with some of our Instagram videos and health headlines, because it almost seems like there's an affront to all of our systemic organs. So they're like, well, I have the means. I'm just going to pay for it.
Yeah. What's the worst thing that can happen?
And there's a lot of things that can happen.
And like, listen, colonoscopies are very safe. We do them all the time, but they're not zero risk either. And when we're screening, we think the benefits usually outweigh the risk, and that's an individual conversation. But if somebody's just more worried, I certainly like to figure out what they're worried about and have that conversation. Like it's not uncommon that I mean, I'm sure you've experienced this too. Like sometimes a patient will come to you, and this happens to me all the time. They want a colonoscopy. They're worried about cancer. They've seen these headlines. And the more you sort of like say, I want to address what's bothering you and what's concerning you, maybe it turns out that their sister died of cancer or that they have a friend. Like you find out like sort of what's really concerning them. And then you can kind of talk through like maybe what the differences and what happened to that person are for them and what is there going on. And I try to understand what the like underlying issue is. But I mean, of course, at the end of the day, we can't do colonoscopies on everyone who wants them, even though like, it feels like, why not? It's a money issue. It's really not. It's like we would cause more harm than good.
You want to maximize the benefit of these.
Yeah. And that's tough. Like, cause when you're one person, you're like, well, I don't care about how this would harm society. I just want to know what's going to help me. And what if you're in that percentage of people who get the complication? Like we always, and then it would have been totally unnecessary.
So this is a good question to ask. Given the rates of colorectal cancer being on the rise in young people.
Yeah.
What should people be on the lookout for symptom-wise?
Yes. Certainly rectal bleeding. Certainly changes in bowel habits. This is the vaguest one, so I'm going to walk through what that means. So new persistent diarrhea, new persistent constipation, changes in the consistency or the caliber of the stool. That means how thin or thick it is. Classically, we think about like new kind of pencil-thin stools. Everyone's allowed to have a weird poop from time to time. Like, so if you have like diarrhea, you ate something weird, maybe you can say that's clearly due to this one other thing. But if it's stuck around for a couple of days, couple of weeks, run it by your doctor. Like it doesn't have to be a big. Yeah.
Worst case scenario, get reassurance.
Yeah.
And a plan of follow-up if it is to persist.
Yeah, totally. I think I have a low threshold. I mean, in my patients, like we use this online messaging system. You could just send me a message and just say like, I've had this diarrhea for 2 weeks. Like, I don't know how to explain it. If it's been going on, like I often will say like, let's talk about it. Like, come on in. But if they're like, like everyone in my family got sick. We ate something, like maybe I'll say, okay, you know what? Like, let's just see what happens over the next week or two, but have a low threshold to just ask somebody about it. Weight loss that you can't explain. You're not trying to lose weight. And then this one's, I think, really important for women, iron deficiency anemia. This is different from, like, a lot of people think they need iron supplements for fatigue in general, but this is not quite just that. This is a specific medical diagnosis. Somebody's looked at your labs. You have an iron deficiency. In women, it's often like, well, it's probably your period, and we lose a lot of iron during our periods. That's true. But if you're somebody who's like, wait a minute, but I don't really have heavy periods, or like this doesn't seem quite right, we'd want to make sure that it's not that you're microscopically losing blood through your colon. So those 4 or 5 things are the things that you should always just double check. Just like make sure your doctor knows everything that you know about your body.
And what about color?
Bleeding. So signs of bleeding in terms of color are bright red stool, maroon colored stool, black sticky stool. And it's not, I don't get excited for dark brown. It's like kind of be like the color of this microphone, black. Like, and you can imagine like GI doctors think like we get a lot of false alarms for like, we think it's black, but actually it's brown. You should always, like I said, take a picture, because sometimes I think you can't tell the difference. Sometimes even we can't tell the difference unless we're seeing it live, but take a picture. If it's sticky, So the reason blood turns black is because when it mixes with the acid in the stomach, it can kind of make it that like shiny, sticky black. That would make me really worried to go see a doctor. And sometimes that sticks a little bit more to the bowl.
Yeah. And in general, what does the color of your stool or your poop tell you about yourself? Should it be changing all the time? If it changes once, should we be worried? What's the general rule?
Yeah.
Here?
Well, I think my general rule is like, except for bleeding and a few exceptions I'll tell you about, like it's okay to have a weird poop from time to time. First of all, I think you should look. Like I can't believe there are people in this world who don't look every time they go to the bathroom. Like, so you should get in the
Crossing
habit
the
of
street
looking.
and pooping.
Yeah.
Always look.
100%. Thank you. Yeah, exactly. Look twice and then look one more time. But like get in the habit of knowing what you look like, what's normal for you, because then it'll be a little bit harder to know, well, what's abnormal the one time you do peek back there.
Right.
But get in the habit of looking. What your color tells you, well, first of all, brown. Most people poop some shade of brown. Brown is not like the natural color of stool. Like brown comes from the bilirubin. That's something that your body is producing, this digestive juice. If you didn't have that bile, the stool would actually be like clay colored. Like it could be like, you know, like the color of that book almost. That's a weird color. That's an emergent, or maybe the color of your shoe. I've seen it kind of like that. That's an emergency color because that means there's some blockage. The bile is not making it.
And not once.
Even once, I actually, for that color, I'd be like, you should run it by me.
Okay.
I'd love to get a picture of that. And like, we could talk about it. But it's certainly, if it persists, we should intervene quickly. Bleeding is also one of those things that even if it's once, I kind of want to know about it. You know, like you could be convinced that you have a hemorrhoid. Let's just make sure it's a hemorrhoid,
right.
You know, because sometimes bleeding from other sources, it happens once, it goes away, and you might brush it off as normal. Let's just make sure, you know, like, let's just like make sure we have an explanation for it. Even if it's most commonly bleeding is not going to be from cancer. Thank goodness. It is. There are these other common causes like hemorrhoids, like fissures, tags, diverticula can bleed, other things. Purple, greens, and yellows are probably what gets into my DMs the most. Like people are asking about
purple poops.
Purple poops, yes.
Ah.
So anthocyanins are these like pigments in berries. Beets will give you a nice maroon stool. If you've had beets like the night before, the day, 2 days before, I'll give you a pass for that maroon stool, unless you're feeling dizzy, lightheaded, like unless there's something else going on, you're in a lot of pain. But purple can happen sometimes even with like red wine. People will drink wine and they'll have a little purple poop later. Or like fun questions that I get in my DMs are like, well, what does it mean when like half my poop was one color, the other half was like another color? Like, why do I have a multicolor, like a segmented poop?
You have a very diverse poop.
Yeah. Yeah. First of all, congrats.
We want a diverse flora
doing
in there.
Something right. Yeah. Well, it can also mean that like, you know, poop, your gut is constantly in motion. Things are moving through your small bowel, through your colon at all times, but it eventually hits this like red light, which is your pelvic floor. And then we decide as human beings, when is a socially appropriate time to go to the bathroom. But your stomach, your gut is still moving at the same rate. So the poop from like the meal you had at dinner, that's arrived. It's sitting in there, but maybe you've told it like, wait, I'm on a date. I don't want to go right now. So it says, okay, we'll hang out. It sits there. Meanwhile, now your breakfast has started to make its way along, and then it kind of mashes up with what you have. So it's not impossible.
And as you said, 7% of the population can't control it.
They miss, and that's okay too. I mean, we actually have treatments for that. So don't feel embarrassed about bringing that up. But it's okay to have a multi-segmented poop because it just means that different parts of your meals have been making away its lung, but they all kind of arrive at the same spot, waiting for you to kind of release it out into the free world.
And what is the number of poops per day that we should strive for or that we consider normal?
Everybody right now listening is going to think that answer is 1, right? Like once a day is like the godly answer. And
well, it's 8 glasses of water a day answer.
Yeah, exactly. Right. Exactly. It's like the number that like somehow
10,000 steps a day. It's like the number ingrained.
And you can't question that number, right? And if you don't hit that number, is there something wrong with you? Well, it turns out that's like another one of those things that if you do a lot of digging about where did that number come from, there's 2 things that I think explain that number. One is There is a time of day when we're physiologically most primed to poop. And
what time of day is that?
Morning time, just like
Why?
Dad told you. So the reason is that your colon, it's a little bit different than your other organs. Your colon actually operates very strongly on a circadian rhythm. So it enters this quiescent state at night. And they've done these physiological studies that find that there are certain moments during the day and with certain kinds of activities that wake that colon up. Because, in order to have a bowel movement, in order to generate that propulsion, we can do a Valsalva maneuver. Like we can bear down and kind of generate push pressure downwards that can help move things outwards. But it's really lovely when your colon contracts and does some of that work for you. Like we feel that urge to go. That's your colon on its own saying, we need to propel this outward. That happens a few times during the day. When you wake up, that circadian sort of reset accounts for probably the most strong contractions you're going to get throughout the day. And it can be augmented by exercise. So if you go for a walk in the morning, if you walk the dog in the morning, you drink coffee. Coffee is like a very strong trigger of that reflex. And then meals in general, like people often have to poop after their like lunch or dinner. Big meals tend to do it. So I think because a lot of those factors convene early in the morning, I think that's how this myth of like once a day blossomed. And like when I was writing this book, I went to the Harvard like medical school archives into these old like Civil War medical manuals. Okay. And they say like in the 1850s, they were like once a day is what we should all be striving for. And they like even swung so, this is like a little bit of like lunacy, but they went so far as to say, if you feel the urge to go twice in a day, hold it in so that you can have that like one perfect form still in the morning. Yeah.
Okay.
Wild. If you look at it like, so actually this was a study that came from my colleagues at Beth Israel. They looked at the NHANES data set and they looked at that subset of Americans who consider themselves to have normal bowel movements. And they said, well, how frequently do you go? And it turns out Americans who think they have normal bowel movements go as often as 3 times a day to once every 3rd day. That's a huge range of frequency that could be considered normal. And once a day is great if that's who you are. But for me, I think the criteria is more like you should be going as often as is comfortable for you and in a way that doesn't interfere with your social life. Like
that you have control over it.
Yeah. If you're going once a day, and I have this all the time, like I have patients who, I'll say like, do you feel constipated? They'll be like, no, I'm not constipated. I go once a day. And then you're like, but you spend 20 minutes straining to have that once a day bowel movement. That's constipation. Like that's not normal. That's not like a healthy frequency to me. We can still optimize that. And if you look at different parts of the world, like there was a study that was done, a kind of similar type of study to that NHANES one in America, where they looked at a population in East India and they said, well, how often do you think is normal? And for them, it was like a median of 14 poops a week was normal. And that's just because they eat a lot of fiber. By the way, if you start meeting your fiber goals, you're going to poop more often. Like that's just, it's a health, like you should embrace that new you because that's healthy. And that's like just sort of this, the softer that stool is, the more easily it's going to come out with with a lot less effort on your part. Your Valsalva doesn't have to like pop an eyeball once you're meeting your fiber goal. So it really just depends on a lot of different things. I don't get so hung up on the once a day unless that's something that makes you really happy.
Yeah. Or if it's been once a day for 10 years and then suddenly it's every 3 days or 4 times a day. And you're like, what changed? I changed nothing about my dietary habits. Something's going on.
Yeah. I think when you have a change that you can't account for, that's a good time to just say, let me just run this by my doctor. But oftentimes I end up telling people, you might not think you've done anything, but there's so much that goes into our bowel movements. It's stress. It's like
travel
subtle,
with the circadian rhythm.
Yes. Yeah. In fact, a lot of people get constipated. Like we don't talk about that enough, but a lot of people can't poop on vacation.
Yeah.
And that's really hard. And it could be your travel. And also people are often stressed while they're traveling.
Yeah. And together in a small room.
With like family members. Yeah, exactly. Or it could be that like a lot of people can't poop at work, or they're like in an environment where they just don't feel safe and comfortable. Like college students. I think college students have like the worst of several social factors. Like they have these shared dormitory bathrooms, like everyone's watching, staring, smelling, judging. They're stressed. They're not eating well. Like they often are the ones who have like a lot of problems. But sometimes you might not say like, oh yeah, I can pinpoint like I changed my coffee creamer or something, like you might not be able to make that pinpoint. But when we take a big step back and say like, what else has been going on in life recently, there's often something that could account for the change.
What don't we know about the science of farts?
You know what? We know so much about farts that this is one of my favorite topics. I've
never seen anyone's face light up as much as I did yours.
I love this subject so much. Okay. Farting was like one of these physiological topics that we studied. Like as a scientist, I feel like a lot of the studies we do now today that are funded by the NIH are like studying interventions and treatments and answering these big questions. But like back in the 1970s, 80s, 90s even, people were just asking these very basic questions about how our bodies worked. And I feel like that was the golden age of farting. So there was this one doctor, Dr. Levitt, who's like a hero in gastroenterology, but he really studied farting.
The fart king.
Yes. You know him.
Oh, no. Is that a thing?
That's his name. That's his moniker.
Oh.
But it was like a moniker he embraced. Like, this is wonderful.
Okay.
Yeah. So I think there's always more to be learned about farting, but there actually is a lot more that we know.
What do we know? Tell me some
know.
fun facts about farts.
Okay. How many times a day would you think is normal to fart? I get this question from patients a lot.
10
to 20. You know, I have patients who come in and they're like, I probably fart more than anyone else I know. And then I'm like, okay, why don't we for the next week, let's count how many times you're going. And then we both discover it's like
fart journal.
Disappointingly low. Yes.
Oh, man.
They keep the journal and you're like, wait a minute, you are right in the median.
That's like, I had that situation occur not with farts, but with hair loss. Patients don't realize they can lose up to 100 strands a day.
Yes.
And they're like, look, I pulled out 5 strands. What is going on? I'm losing. I'm like,
so average.
So average. Like you're below average.
Yeah. Yeah, exactly. In fact,
you could lose more.
Fart more. Yeah.
Okay. So that's how much we fart.
Farting a lot. Okay. Here's a good one. Whose farts are more offensive, men or women?
Offensive in volume, in follow through, in scent.
You're asking the right follow-up questions. There was a study that he led.
The Fart King.
The Fart King, where he was trying to say whose farts are more offensive to the average human nose.
Oh, nose. Okay.
Yeah.
So sensory thing.
Yeah. Not like your sense of propriety. I feel
like men get blamed for farting more, so maybe men's are worse.
Yeah. I think that's true. I also think that here's what the data says. So they did this.
You're like, personal anecdotes aside.
You know what? I have an opinion, but I'll just tell you the science. They did the study where they looked at, first of all, the experimental design is like the best part of this story, like more than the results. But basically they hooked up a group of men, and it's a small cohort, but enough, of men and women. They had them eat like what they called a flatulogenic diet of like beans the night before.
Okay.
They hooked them up to a rectal tube.
Because they're good for your heart and they
help you.
Fart.
Thank you. They hooked them up to a rectal tube that would collect all the gas and into this chromatograph, and they would measure it. Okay, that's step one of the experimental.
Yeah.
I know. All right, but this is why you can see why, as a little girl, I wanted to do GI science, right?
Yeah, totally.
Yeah.
You were dying to put rectal tubes and collect farts for chromatography.
Yes. So they looked at men, they looked at women. And what they found was that, so first of all, 99% of our gas is actually odorless. It's the 1% that contains sulfur that is responsible for the bad smell and that ruins it for everyone else. They found that female farts were more concentrated with sulfur. So stronger smelling than the men's. However, men had a greater amount of volume per toot, such that...
Is that a mass scenario?
Yeah. In how they measured it.
No, meaning, is that because men on average are larger mass?
No, actually, I'm probably the men were slightly larger than the women, but I don't know if the volume has more to do with your sex than it does with your size of rectum. I have to think about that.
Well, because on average, even if we think about muscle mass or mass in general, if they're large, was it controlled? Because if you controlled for the size and you said, well, this 118 pound versus 180 pound individual. You're
asking a good question. They didn't.
It's like Journal Club for Farts.
I know. They they did not control for like kilogram or BMI, which is an imperfect measure, but I wonder if it would have been a good measure for this particular question.
Sounds like we have some research to do.
I think there's room to do the
I'll
follow-up
get the funding
study.
for this. Who makes...
He was funded by the NIH. That's the best part of this. Yeah.
Well, I mean, who's going to get mad if a bean company hires us? No one's going to claim that we're doing some kind of
that we're funded by
corrupted
Big
work.
Bean.
Yeah, Big Bean.
Yeah. I mean, I think if we're helping people answer some of life's most important questions here.
I don't even know who makes bean. Goya? Who's a bean manufacturer now?
Yeah, Goya sounds right.
Goya, right? Yeah.
They're listening.
Well, because I'm watching Mad Men, you know, the show.
Oh, yeah.
And Heinz was
you're
making
rewatching.
beans back in the day.
Oh, yeah.
So I don't know if
That's right.
Heinz still makes beans. Sam, do you know?
Those are the beans my British wife and I have with beans on toast.
Oh, look at that.
Ooh, yeah, that's a classic breakfast. That's a nice high fiber breakfast, actually.
I know why Sam is suffering now because there's beans and there's the heavier
and then there's
sulfur
the result.
load.
Yeah, the result of. It seems that, so if we take apart the possible confounding factor of the mass, I don't know the answer to that. It seemed that the volume in general that the men produced was larger. So that the second part of the experiment was they've collected the gas. They had a group of volunteers smell the gas and rate the gas in terms of how offensive it was.
Okay.
That group of independent noses thought that it ended up equaling out, that there was no real winner between men and women because there's only losers, because the women might have been more concentrated technically. However, smaller volume, the larger volumes was more offensive.
Wow.
Yeah.
I'm learning so much about farts. Okay, so we have
The more you know.
limited difference between the gender.
Yeah.
The amount that we're going 10 to 20 times a day is normal.
Yep.
And
Can you prevent the smell? That's like the number one question I get from people in my clinic.
Are people looking to prevent the smell of a bad fart?
I mean, suppose you have like this hot, first of all, of course they're looking to prevent the smell. Like,
Are they?
Suppose you
Is
have.
that a concern people have?
Yeah, I mean, I think
I mean, 12 years of seeing patients, I've never had that as a question, let alone a concern.
You don't run a GI clinic.
Clearly. But
Or
tell me, like, what?
Maybe
so
you're
they're
not creating
saying
a safe enough space for people.
I need to be more safe around fart scent. So wait, they're coming in and they're saying, hey, my farts are clearing out a room. What do I eat?
Yes. Okay, I will say I don't think I've had someone come in with their primary question. Like they haven't made a whole visit for this, but
okay,
it'll
got
be
it.
like, by
A
the
side
way,
question.
like I have this like date coming up. This has like always been a problem.
Is there a fart supplement that you're about to pitch right now?
Not quite.
No. Okay. So how do we make farts smell better?
There is a substance though that's already on the market, which is bismuth subsalicylate.
Oh, Pepto.
Yeah, it neutralizes sulfur.
Wow.
Yeah, so I don't make any money off of telling people to do that, and you obviously shouldn't take it.
But then we're going to get all
long-term.
black stools and everyone's going to freak out.
I know, and then they'll come right back.
Exactly.
But it can.
Yeah.
If you take it the day of, high risk event, you're like at your family Thanksgiving with your in-laws, maybe.
Interesting.
Pop a little Pepto.
You know, all of this conversation about black stools, iron deficiency, anemia, hemorrhoids got me thinking.
Tell me.
I'm putting this out there. This is a new theory that I've developed in the midst of this conversation. Theory is a bad word for it. A very wild guess. Would you find it interesting, given the rates of increases in colon cancer in young people, and that a lot of times we blame rectal bleeding on the hemorrhoid, which sometimes could be because of the hemorrhoid, even though we examine and we see the hemorrhoid,
Yeah.
that there's a link with iron deficiency anemia in young people,
Yeah.
that if someone is iron deficient and not very clearly losing a lot of blood due
Not
to their
clearly.
menses, not clearly,
Yeah.
or they have a hemorrhoid and still we recommend them getting not a colonoscopy, but like a Cologuard
Okay.
in younger people, because we're like, yeah, your rectal bleeding is probably from your hemorrhoid, but because some might be slipping through and not be from your hemorrhoid, we would never know the difference. So maybe we should screen this population.
The problem, unless I've misunderstood, is the problem with the Cologuard is that you're going to get a lot of false positives triggered by the hemorrhoid, right? Like,
But the Cologuard doesn't just check for presence of blood like those FIT tests, right?
Yeah, it checks for the DNA.
Yeah,
too.
exactly.
You'll still get the false positives.
Oh, really? Okay.
So, it's best for people where there's not another possible source of blood being introduced
Got
that
it.
you're aware of at least.
Got it.
But I wish there
Because
was.
it would be good to screen those people, because our usual symptoms that we would use to do a diagnostic colonoscopy are kind of not great because it's being hidden by, oh, I get frequent hemorrhoids. That's why there's blood.
It could be in the future, and I think we don't know the answers yet because that kind of study hasn't been done. But like the blood test, for example, that could be a place where we say like you're someone who we might put down as like lower risk overall.
Right.
Let's like just do the blood test, right? Because
Right.
then you're not introducing like this like kind of confounding factor.
Exactly.
Maybe that's the way. I have to. I mean, I think the blood test is. We haven't used it probably as much in clinical practice yet as we should, but I think it's a great. There's some people who are just never gonna be able to make it for the colonoscopy easily, but when you have a positive like stool kit, that's enough to say like, okay, let's do it. And I think if you can just catch them while they're
And
there.
how good is the blood test? I'm not familiar with its sensitivity, specificity.
It came out within the data is like within the last 2 years. It came from Mass General. It's pretty good. The issue with both of those
is
and
the high
they're
false
great.
positive.
High false positives, but also more like you will miss polyps. You know,
Well, of
like
course,
yeah, like you do.
Can't intervene. There's no intervention.
You can't intervene, and you don't know. Like the stool kit detects some polyps, but it's just not as good. And I think you can like live with this false sense
When you
of
say
security.
stool kit, what are you referencing?
I'm talking about the combined, like the Cologuard,
Got it. Yeah, interesting food for thought.
if you will.
Quite literally in some regard. Final 2 questions.
Please.
1, biggest piece of misinformation you're seeing surrounding people's poop.
Oh, where does it end? Where does it begin?
I would say the anal sphincter is probably where it ends.
The internal and external. Yeah. I think that this is maybe bigger and broader than you meant because I know we've talked about a lot of the like big misconceptions, but I think a lot of what has actually changed my own opinion about myself and what I do is that I think a lot of times people think about certain gut health diseases or even neurodegenerative diseases as diseases that affect older people. Constipation comes for you when you're older. Parkinson's comes for you when you're older. And cancer is a disease of older people. And I think a big misconception is that Parkinson's, what I study is actually how that protein that misfolds, alpha-synuclein, in the brain in Parkinson's disease, we study how it misfolds in the gut decades beforehand. And so I think it's important to take care of your gut when you're young and healthy, when you don't have symptoms,
Sure.
long before that's the issue. And I think that's also the time in your life when you may be least likely to want to pay attention to those things.
Yeah.
You know, and the flip side of that is that I also meet a lot of people who will say like, they'll meet me in their 30s and 40s and they'll say like, gosh, when I was in my 20s in college, like I was a wreck. I didn't treat my body well. Like, am I doomed? You're not doomed, right?
Yeah.
Like with almost any disease, intervening at any point to make a change will start to lower your risk by some amount. So
Right.
it's never too late. It's also never too early.
Yeah. And if you were to change one thing about the field of gastroenterology, what would you change? You have a magic wand. You can fix anything.
Oh gosh, I love our field so much. I think our people are so fun. This is what I would change. And I think we're trying to change it. I wish we had a way to safely get a cross-section of somebody's enteric nervous system, get to the muscle layers in a routine scope. Because I think, if you think about liver disease, before we were doing like percutaneous liver biopsies at the bedside, we were diagnosing liver disease based on blood tests, based on jaundice. Like, did your skin turn a little yellow? Is your eyes turning a little yellow? And history. We were like, well, what are your risk factors? It was not based on histology. It was not based on what the cells look like. In a lot of ways, that's where we are right now with so many disorders like irritable bowel syndrome. We're saying you have irritable bowel syndrome because you have pain when you go to the bathroom and you poop X number of times, per week. But what if we were making that diagnosis based on this specific pathology we were seeing in your
Right.
enteric nervous system? We're not doing that because right now we don't have the technique.
Right.
We don't have a way of safely getting that deep into your muscle layer without creating a perforation, without sending you to surgery to get it fixed.
Naive question.
Please.
Do you know what an EEG would look like for someone's, like to diagnose carpal tunnel or to look at their distal nerves?
Yeah.
You send one signal, you catch it on the other end, and it shows if there's compression of the nerve, et cetera.
Yeah.
There is no world where there is like a intestinal EEG.
You are referring to the electrogastrogram.
Oh, that's a thing.
Yeah,
Okay.
the EGG.
Do we do that for anything? Can this be the substitute for your enteric study?
So funny. I've studied the EGG
Okay.
extensively. And you're onto it in that, like, our stomach, just like actually our entire intestines, it has an electrical activity, a regular rhythm. Your stomach contracts at 3 cycles per minute. You can capture that on an EGG. It does correlate in some ways to changes like that we might see in something like gastroparesis or delayed gastric emptying, but it's not quite.
It's too macro, not micro.
Thank you.
Okay.
Doesn't quite get us there. Doesn't quite get us there. But I do think, I mean, this is like an emerging frontier. A lot of the advanced endoscopists, like the interventional endoscopists, they're innovating ways to safely do these types of full thickness biopsies. There are a lot of cool research papers about this. So I think in the next 10 years, we're going to get there. And I think when we get there, the field is going to explode. We're going to completely change how we diagnose, how we classify these diseases. And I think then how we treat them, like the innovation around therapies is going to totally change. And I think it's going to benefit the patients.
I think it's also going to destroy, thankfully, some of this predatory supplement world surrounding GI disorders.
Yes.
Much in the same way, I don't know if you felt this, especially because we grew up in the same time frame. When I was 15, 20, I'm sure you were watching infomercials at some point. There would be all these weight loss ads.
Yes.
And now there's none because we actually have a medical treatment that works for weight loss.
That's true. Jenny Craig was such a thing, right?
Right? I mean, like how many grapefruit cleanses were playing on
all
this stuff. But now there is zero commercials.
We don't need it
because
anymore.
we don't need it.
Yeah, that market is gone.
And they'll just keep moving on to the next thing that they want to try.
Yeah, people still come to me talking about cleanses. That I guess it hasn't totally gone.
Cleanses for detoxing now.
Yeah.
But now weight loss.
Yeah, right.
Yeah.
People think they go hand in hand sometimes, though.
Well, we solved it today.
Yeah, we did.
Thank you so much for teaching me about poop and farts. Where can people follow along your journey?
They can follow me on Instagram, TikTok, or they can check out You've Been Pooping All Wrong.
Share your full handle so they know where to look.
Oh, yeah. Trisha Pasricha, MD.
Okay. There you go. Thank you so much. Hopefully you had fun.
I had a great time.
Awesome. Thanks. This gentleman only eats syrup. Seriously. Click here to check that out. And as always, stay happy and healthy.